So next up we've got Dr. Abi Hall, who's from the University of Exeter, presenting works from our PhD. So looking forward to hearing what she has to say.
Hi, good morning everyone. I'm not quite used to being called a doctor yet, so thank you Dave, it's a bit strange still. My name's Abi Hall, I'm a community-based physio working down in Exeter, and today I'm presenting work from my PhD, which is looking at community-based physio for people with dementia following hip fracture. So I'm going to go through some background briefly. I'll then explain different components of the research program I undertook and try and summarise the 3 years of work, hopefully in a few slides, and then come up with some recommendations for clinicians. So just some background, and I think it's probably figures that won't really surprise anybody. We have an ageing population, I think we all know that. By 2050, we estimate 21% of the world's population are going to be over the age of 60. With increasing age, there's obviously the increasing risk of physical impairments and disability. But we also know that rates of dementia are increasing, the so-called global epidemic. In 2013, there were 44 million people worldwide with dementia. By 2050, this is going to increase to 135 million. And in the UK, the picture is similarly increasing. In 2014, we had 850,000 people with dementia. By 2050, in the UK, we're going to have 2 million people with dementia. So the things we know are that falls are a major problem for people with dementia, with an annual incidence of around about 70 to 80% of people with dementia who fall every year at least once. And 10% of these will result in fractures. We also know that hip fracture is a massive risk factor for people with dementia. Around about 40% of people who fracture their hip will have dementia as well. That equates to around about 28,000 people per year in the UK with dementia who fracture their hip. And it's expensive. So it costs around about £1 billion a year to look after these people from a health and social care perspective. But we know outcomes are also really poor. So around about 60% of people will end up in permanent long-term care. So the first part of my PhD was a scoping review, and it was looking at what current evidence there was for physio treatments for this population in the community. And we identified just 26 papers, and of these, only 9 focused explicitly on physio interventions. Where they did focus on physio, there was really inconclusive evidence for the use of physio for this population. Where it was recommended, the papers failed to actually describe what the physio intervention was. So as a clinician, I couldn't replicate that intervention at all. There was also a real lack of qualitative evidence describing the experience of people involved. So the scoping review led to 3 qualitative pieces of work being undertaken. The first explored the experience of physios treating this population, with particularly focusing on the challenges they faced, as well as recommendations for effective treatments, methods and techniques that they could use for people with dementia. The second qualitative study explored the experiences of people with dementia actually receiving physio. And the final study, as part of the PhD, explored the reasons why people with dementia were often not even being referred for physio in the community following a fracture. So I'm going to try and summarise the results of each study in order. So the first main finding was around the practical challenges that physios face delivering the intervention, but also around the challenges patients face receiving the intervention. So the first big thing was around the environment. This was mentioned by a lot of physios and also by a lot of patients. The acute setting really wasn't seen as the ideal environment to be able to rehabilitate these people. Physios really described the fact that patients struggled in this environment. They struggled to understand what was going on. It was confusing, it was difficult for them. But actually, this was the phase at which people's potential to improve was quite often determined. Patients described it as really confusing, that acute setting. Most of them couldn't even remember what had happened in the acute setting, let alone anything else. It lacked consistency for patients. So patients described to me how they saw 3, 4, 5 physios during their time in the acute setting. They didn't have time to build a relationship or start trusting those physios. Patients and carers described how hard it was to even obtain physio in the community. People kind of assumed that physio would just follow on, following the hospital. They would just receive it in the community. But that didn't happen. People described how difficult it was to get physio to come see them in their own home. They described it as kind of a fight, a real battle to try and get that physio. Patients and carers said that physios were quite risk averse. One example given to me was a really good example, I felt. The patient was given so much moving and handling equipment, there wasn't actually space to practice walking in the house. Physios kind of agreed with this. They said they were quite risk averse. They were with them. So it was a real kind of juggling act between the physio of potentially creating more risk by getting them doing more, but also not doing enough. And resource pressures were mentioned by everybody. So physios really described how they didn't feel they had the resources to be able to treat people enough, give them what they needed. Patients realised this. They really understood that physios didn't have the resources to give them what they, as the NHS, we were doing our best, but they didn't get what they felt they needed. Many of the things we came up with related to around this stigma of people with dementia they felt about having a diagnosis of dementia. And this first term probably won't surprise anybody. It was a term that came up a lot during all the qualitative work we undertook. So rehab potential was really seen as a determining factor about whether somebody even received physio in the community. And the presence of dementia quite often meant that people were assumed not to have potential, but it was decided very early. But that label of not having rehab potential followed them through into the community where they didn't receive physio. Physios felt it was quite difficult to justify providing physio, long-term physio to people with dementia, whereas they could potentially rehabilitate people without dementia much faster. They felt as though commissioners and managers would question why we were seeing somebody for so long. Delays were reported by a lot of people. People quite often said that their relative waited months and months to be seen by a physio when they were discharged home, by which time the patient wasn't mobile at all, and it was almost too late to try and start rehabilitating them. And patients, quite interestingly, didn't always feel comfortable in disclosing their diagnosis. They felt as though if they told someone they had dementia, they might not receive the best treatment, they might not receive the same as somebody without dementia. And one carer gave me a great example. Their relative wasn't eligible for a rehab bed because they had a diagnosis of potential mild dementia. So the actual intervention was discussed by everyone really, and it varied quite considerably, which I was quite surprised about. Physios and patients described how therapists would often see them at home quite quickly after discharge. This wasn't really for rehab, it was kind of for a safety check, to check they were coping at home. But rehab didn't necessarily follow. In fact, that might be the only input they received from the therapists. When they did receive physio, interventions were often quite limited. So people may have only received 4 to 6 sessions in the community. But people did say quite often these were cancelled. Physios felt they could only offer a small number of treatments before discharging a patient if that patient wasn't showing signs of progress. When treatment was offered, it was often quite generic. So people often described to me they were given an exercise booklet, so staying steady exercise booklet or a target exercise booklet, but they weren't given individualised exercises. And there's this kind of feeling of therapeutic nihilism, whereby it was assumed the person, because they have dementia, they might not be able to improve, and therefore they weren't always offered treatment in the first place. Knowledge was seen to be a real key determinant as to how a person with dementia was rehabilitated following a fracture. So physios describe little or no training in how to treat someone with dementia. They often relied on kind of learning by trial and error, trying something, seeing if it worked, brilliant, replicating it, or seeing something that didn't work and therefore not doing it again. Physios really sought out further education. People were desperate to get more training on dementia and how to adapt their treatments. They simply couldn't find the education they needed or wanted. And people described a real kind of negative perceptions about people with dementia. They felt they received a less good service than those people without. And this was really related to a lack of public knowledge about dementia in its entirety. So as well as the challenges that people reported about treating this population, there were quite a lot of recommendations that physios felt would be beneficial, but also that patients and carers felt would have improved their care. The first thing really was that the interventions needed to be timely. They needed to be delivered quickly on return home. Any delay in seeing that person at home meant that the deterioration was quite quick, and often that wasn't resolvable. It was agreed really that everybody needed more education and knowledge about how to treat people with dementia, about how we adapt our treatments to treat people according to the dementia. Assessments and treatments needed to be much more functional in their basis. So working on trying to improve functional outcomes rather than looking at biomedical outcomes. Treatments needed to be individualised, so very specific to the person's needs, actually what they needed, not just a generic exercise booklet. And involving carers was absolutely vital. People really wanted their carers to be in, or relatives to be involved where they had any. Not only just engaging them in the rehab, but also encouraging them to continue them. And goal setting was really vital. So the goal setting needs to include the person with dementia to actually set goals that were meaningful to them, something that actually mattered to them. We found it was quite difficult when goals weren't effectively set. There was a real lack of sort of understanding of the aims and the purpose of physio. And it quite often led to frustration where the physio thought that the treatment was ongoing, the physio felt that the treatment had completed. So goal setting was really, really important. So really in summary, we found that there was an element of therapeutic nihilism where people assumed that because they have dementia, they couldn't get better and therefore simply didn't try. The term rehab potential was absolutely vital in determining what the future of their rehab journey looked like. And the use of the term, I think, needs to be used with great caution, but also given context, because without this, it prevented people in the community receiving further input. I think there is a stigma around people with dementia, and it did affect the treatment that people received. And we as physios need greater education about how to treat someone with dementia. But it's important to say that people with dementia can be rehabilitated. We just need to change our approach and our beliefs about how we do this. Thank you.
Okay, thanks very much, Abi. I think you'll agree that's quite a PhD, so congratulations, Abi. It's really interesting. So can I invite the three speakers we've just had to come back on stage? Now, because we're streaming this, if you could cluster around